you who is here. This meeting is being recorded for people to see because some people can't see it today. And this is such an amazing outreach tool. We think it's just great to have this available for so many different folks. But again, so thank you all for being here today. My name is Tyree Cobbins. I work as a prevention navigator for Southern Tier AIDS program. And I specifically work in our Communities of Color program. And what my job pretty much is specialized in is helping, communities of color in our area get resources that they need. We do HIV testing, STI testing, navigation, things like that. And we really just try to give folks the most help that we possibly can, to the people who really need that help. Let's see. So today's seminar forum is HIV as a racial justice issue. And I just want to take some time to introduce two amazing people who I am so grateful to be having here today. They are just so amazing and accomplished and wise beyond any possibility. So thank you to our speakers. I want to get in here and actually introduce these awesome folks to y'all. So I will start with Ian. So we have Ian L. Haddock here. Ian L. Haddock is the executive director of the Normal Anomaly Initiative, an organization focused on the forward mobility of Black queer persons. This organization is the creator of Black Queer Plus Center for Liberation, the Positives Organizing Wellness and Resilience Project, the faith-based project called Outcry, and a founding organization of the Transgender Allyship Collective. Describing himself as an activist, he is a part of many organizations, including working in the communications department of NASDAQ and serving as president of Impulse Group Houston. He has written for Huffington Post, The Griot, Logo, and The Body, and serves as the LGBTQ editor of Real Urban News. Haddock has been awarded Trailblazer of the Year from African American State of Emergency Task Force and the Dr. Mark A. Collum Emerging Young Leader Award from the National African American MSM Conference. I want to applaud because I'm so used to, I would think that we would be like in person with an audience, but thank you, Ian, for being with us. And now I want to introduce you all to Shani Wilson. Shani is a nationally certified physician assistant who completed her Bachelor of Arts degree at the Rochester Institute of Technology. Shani specializes in internal medicine and medication-assisted therapy at Trillium Health, which focuses on meeting the needs of LGBTQ plus people, communities of color, and underdeserved populations. Shani works hard to give a voice to communities in need in the Rochester area. She's one of the co-organizers of Rochester Black Pride. Additionally, she is a leader in promoting workplace diversity and inclusiveness. She's currently chairing the Police Accountability Board in her area. Recently, Shani was appointed to the American Academy of Physician Assistants Diversity, Equality, and Inclusion Commission. So thank you for being with us, Shani. Thank you so much for giving us your amazing talents today. Thank you both for being here. So I want to open this up. I kind of want to, this is a conversation, it's a forum, but I really want to have a conversation with you both and just kind of talk about some things that may make some people uncomfortable, but if people do feel a little bit uncomfortable, I think that's okay, because the things we're talking about today are things that really need to be talked about to, to a lot of the masses. I want to start with this first question for both of you. And I want to ask you, in your own words, what are social determinants of health? For folks out here who may be listening to something like this for the first time, in your own words, what are social determinants of health? Either person, someone wants to start. I'll start with Shani.
Okay. Hi, everyone. So thanks so much for having me here, Tyree, today. It's nice to be here with you all. Greetings from Rochester, where it's raining and crappy outside. So it's nice to do something fun today. So I do want to make a clarification. I no longer work with Trillium Health. I actually work at another federally qualified health center. I left that place because I actually am full-time working for a full-time volunteer with the Rochester Police Accountability Board. It took up so much work that I actually left my full-time job to pursue this area in politics. And so
Oh my
I want to make
goodness.
sure that I clarify that. Okay, so I just work in urgent care, so that's what I'm doing. But so I would say social determinants of health in layman's terms is really the, as a clinician, it is all the other issues, factors in my patients' lives that contribute positively or negatively to somebody's health outcomes. Where they live, where they shop, where where do they catch the bus? Where do how do they have a good relationships with their parents? Do they have a car? Like, do they have access to food that's within walking distance of their home? Can they get to, so those things, it's like the nuances of everyday life that contribute to health outcomes is what I would say.
Okay.
I appreciate that, Shani. That first of all, I'm honored to be here, honored to be on a panel with you, and thank you, Tyree and Stop, for inviting me. So I want to frame this a little different. I'm so grateful that Shani started first so that we could get a really good concept or conceptualization around social determinants of health. I like to call them social determinants of equity, right? Because when we think of social determinants of health, we sometimes get this linear focus on what is keeping people from accessing healthcare. But really, when you think about marginalized communities, right, the reality is what is keeping them from accessing healthcare is the same thing that's keeping them from accessing many of the necessities in which they have for their lives and or priorities. And so for me, social determinants of health or social determinants of equity is the disease. HIV is the symptom, right? What do I mean by that, right? So in terms of what keeps people from engaging in care or not seroconverting, right? It really is about all of the diseases in which are pervasive amongst these communities. And so when you think about homelessness, if you can cure my homelessness, you might be able to help me with my HIV. If you can cure my
Right.
poverty, you might be able to help me with my HIV. If you can
Right.
cure racism, right, then we might be able to deal with HIV. And so when we have these conversations around social determinants of health, many times I think, and it's important to frame it as what it is. This is the definition of social determinants of health. But in terms of the work that we do, why it's so important is really about this idea that we have to cure all of these ancillary issues that really impact the symptom, which we see. HIV, getting seroconverting or getting a positive HIV test is really about all of the other things, right? Why
Mhm.
didn't this matter for me? And so social determinants of health are all the reasons why they can't matter. If I'm poor, if I'm broke, if I ain't got no money, no education, if I can't get food, all of those things impact the way I have sex and the way I move, right? And so
Mhm.
those are really the diseases that we have to fix before we get to the symptom of HIV.
Mm. I like the way you put that. It's almost like the social determinants of health. They start it, and then the HIV is just kind of just like the cause and effect. I guess is the words I'm looking for. Cause and effect. Social determinants of health, those are the cause. And then HIV is just the effect of it. And what you're both saying is, in order to handle the HIV aspect of things, we have to handle the social determinants of health aspect before we could even get there. So I love that you both said that. And when it comes to social determinants of health, I want to take a second to focus on one specific one for my next question for you, and that's stigma. Because stigma is a big thing within our fields when we speak about HIV and STI help. And you know, the dictionary defines stigma as a mark of shame or discredit. And in our fields, the fields that we work in, you know, I think we've all had to deal with that. So I would like to ask both of you, how has stigma surrounding HIV affected your job as a public health worker?
Yeah, I'll start this time because Shani was so gracious to start the last time. Thank you for starting this conversation off. So, you know, I didn't get into public health or community activism from an academic lens, right? I am a product of my environment. What does Ian mean when he says he's a product of his environment? I got into this work because I was a sex worker, right? And I was extremely into sex work for several years, and then I was going to a particular clinic to get tested often to make sure I could do the work that I was doing. And they were saying, wow, how are you not contracting HIV? Right. So this is before I got on PrEP. This is before all those things. And so my lens is really a little bit different than most people who get into public work for either seroconversion and or because they are medical practitioners in some kind of way. So in terms of me, stigma looks a little different. I think there are so many intersections of marginalization in which I have privilege and that I have to, in leading my organizations and leading the work and saying what needs to be said, causes me to really look at it from a different lens. I think stigma is, I was having this conversation this week around stigma and how stigma is so it's no one can really define stigma. You ask 10 different people what stigma is, no one can really define stigma. And that's because stigma is really the silent killer. And working in public health, it's been so interesting because I didn't come from an academic lens, I didn't have all of the jargon and able to have the conversations correctly or say what, you know,
Right.
people were saying. And what would happen is I would go in there and I would say, but for the people who are having condomless sex and like it, what do we do? And everybody in that space would look at me like I was crazy. Until at some point I got enough gumption, as my mother would say, to say, I am the one having condomless sex working in public health. I have condomless sex. How are you preventing me from getting HIV? Right? If you need a face for somebody, how are you preventing me? And I think for me, the community is really clear. I think we still have a lot of work to do with stigma as a construct, and there are a lot of work to do around making people more comfortable and visible, and visibility is important. But my issue really is how public health treats reality. The truth of the matter is there are a lot more of us having condomless sex than there are us using condoms 100% of the time. And so if we have conversations around HIV prevention and HIV care from the lens of use a condom, treatment as prevention, and we're not really treating the whole person, really being honest about the fact that condomless sex is natural sex. So how do we help you have natural sex if that's your choice in the safest ways possible? I think that that's how, in terms of like public health, how I've seen it show up constantly and consistently.
I love that you said that, Ian. You just touched my soul. Shani, how about you?
Yeah, so I would say, you know, when Ian was speaking, I was really thinking of, you know, the Ta-Nehisi quote about, you know, racism, how it breaks bone, you know, rips out throats and breaks teeth. And, you know, my experience in medicine is I really liken stigma to that type of visceral type of response, type of thing, because I see how it just rips through the community. It's kept people away from healthcare. It's kept people, like I've watched people die from AIDS. just in the last couple of years, right? We're talking about age-related illnesses they haven't seen since the 1980s. There is especially within the Black and Brown communities, there is the stigma of shame that is robbing people, that is breaking bones and teeth, right? That is really literally taking them and reducing them down to just nothingness. And so when you try to, me as a clinician, working it out in the community, trying to figure out, well, how can you make space? How can you make time? How can you, enlarge spaces that people can feel comfortable maneuvering, meandering in a place where you can still address their needs as Ian was saying, on their own terms, but understanding that they still have to have healthcare, right? At this point in medicine right now, especially within our community, it is literally a lifeboat situation where you're literally trying to save everybody that you can, right? I think that for stigma though, it just seems much more, there's the visceral reaction, and then there's the insidious part where it is, it doesn't come out until much later, until you don't see a patient for 2 to 3 months and they all of a sudden have cytomegalovirus, or they have some sort of encephalitis from their HIV that has been undertreated, or some other issue with mental health, or some other issue with just primary care needs that aren't being addressed. So, and even in the community as well, we have folks that, see they're stigmatized by their place of worship. They're stigmatized by people within the queer community. So there's different factions of stigma. There's different places where it exists, but it still does the same thing. It isolates, it otherizes, and it puts people in a place where they cannot get consistent help.
Okay, so you kind of touched on my next question for you, because as you were saying that, it all is just playing clearly in my head, and I'm thinking, when I think about stigma, my question for both of you, I guess, is how, if you can, say that you see this happening, how does stigma impact really correlate with that HIV impact, specifically in communities of color?
Can you say that question again? I'm just trying to process what you're saying, if you mind.
Yeah. So how does that specifically, I guess, correlate to the HIV impact in communities of color specifically?
Yeah, so we talked about our positive organizing wellness and resilience project. And that's a project that's it's led and for exclusively persons living with HIV that identify as Black and or queer. And so we just did our last cohort. I was not a part of it because I'm not a person living with HIV. And even as the leader of the organization, I want to make sure that that is an incredibly safe space. But in terms of the evaluation and the staff person that was leading that particular thing, there were a lot of nuances, right? Even in a space that is supposed to organize, build wellness, and create some resilience or empowerment for persons living with HIV. What we found out is that they don't feel safe, and moreover, there's not a reason for them to want to be brave, right? And I think a lot of it is around like policies, like criminalization, especially I'm here in Texas. So criminalization is a real thing here in the South. And all of it is related to patriarchy and white supremacy culture. Ian, why are you saying that? It is related to patriarchy and white supremacy. Yes, I answered my question. But it's related to it simply because when you think of the policies that are in place, they are to protect the clean, the good, and the well, right? They're not to protect the marginalized, the oppressed, and the affected, right? And it doesn't help anybody. But we have even bought on in communities of color, specifically the Black community, right? We have bought on to this idea around criminalization for HIV. Why? Because it quote unquote works for us. But really, as we're having these conversations around these policies, we're looking at public health movements and things like that. It really doesn't work for us. You know why? One, because it puts more people in jail potentially. So that's a whole other issue. But moreover, and more importantly, it keeps us from having autonomy and responsibility over our bodies. Sex is one of the most free and liberating things. But when we think about the stigma surrounding HIV, we only think about that after the orgasm, right? And that's what criminalization does. It says, you go do this, and then you deal with the consequences later, when it really should be deal with the responsibility of having sex, right? And
Mhm.
then go forward with having sex. I am a I'm definitely an opponent of criminalization, specifically as it relates to stigma in communities of color, because even though I am not living with HIV, I take PrEP every day. I take PrEP every day because though I'm not having a lot of sex, if I have sex, there is a 50-50 chance that it's going to be condomless. And it
Right.
is not anybody else's responsibility to take care of my body. I have full autonomy over my fatter, Blacker body. And that looks like for me, right? Taking responsibility and not forcing somebody else to have to take responsibility of that cost. And so just wrapping it back up, this patriarchal white supremacist culture in which stigma is pervasive, we gotta recognize that even though these things may feel good, they may look good, these structures and policies may seem like they work for us, they actually are outside of us, and those things create a level of stigma and comfort that we, as public health professionals, have to work against.
I only have a tiny thing to add to all that, like all of that, like all of the things encompasses everything I want to say. I think the thing that I deal with within our community is just the stigmatization between community members, and not even, and that is, I think, where the most hurtful, the most damaging, argue me down, issues occur, especially when you're talking about, a lack of medical knowledge, right? A lack of health literacy, right? You talk about, like, folks, I diagnosed two new HIV positives last week, and there were 3 in the clinic total. Both of them were Black cis men under the age of 20, and telling them about, both were homeless, both had no family contacts in the area, both were survival sex, and both were living with somebody that was not in a safe situation, right? Trying to ask about their family, trying to get them help, and they're like, well, I'm from down south, I'm from Philadelphia, right? So there's an element in our community that we have to talk about. How are we going to help the young ones? How are we going to help the ones coming up? And we have a generation of kids, folks that are just lost.
Right.
We're also responsible for bringing in those folks, right? There are some, I have a friend of mine, Adrian Elam. They're now in New York City, and they talk about being the gatekeepers. Some of us are gatekeepers for our community, and we have to keep sounding the alarm, making sure that we're like, we see these folks and we just shake our head about, well, what are they up to now? Instead of like, then 3 weeks ago or 3 weeks later, they're in my clinic, right? So
Right.
like that's a thing too. So let's talk about that.
Yeah.
We need to take on a greater responsibility. And also, I'm just going to go on and say it as well. A lot of these older folks that have lived in the community and lived through the AIDS crisis, lived through HIV, are now, again, argue me down, at a place where they're just trying to survive past the pandemic that they lived through, right? Some of these folks have lived through 2 pandemics now, right? So they're just like, it is trying to engage the older community in this type of advocacy has been really difficult for me, because they just want to just live their lives because they've already lived through so much. So then where's that type of mentorship? Where's that type of having some of these older folks that are pouring into the next generation? So there are some real issues there, that it is our generation, it is us that also has to come around, gather around our community, and also help our community to survive.
Wow, thank you both for that. You both kind of touched on something that I I want to shift my next question to, and really everything that you said was so poignant, and I want to add another kind of different ingredient to this pot that we're kind of, cooking up right now. And I want to talk about white supremacy culture, as Ian, touched on. And with the stigma, how you both touched on the effect that it has on the communities of color. Do you think that white supremacy culture plays into this? And if so, how?
Oh, I mean, that's like asking if the air, like, is the oxygen you're breathing, right? Like we are literally trying to, like, we all live in a house that we didn't build, right? But
Right.
we are trying to figure out how to literally build our own spaces. I think the thing is too is like it is so much a part of our lives, and we are just, I believe, in the last couple of years, especially in Rochester, we had Daniel Prude died. This was the city, right, where we've been dismantling what public safety looks like here, and that is also rooted in white supremacy. But it is a reimagining of our public safety system, and reimagining of what it is like to live in this type of system. So it's, of course it does, all of what we deal with does. And I think the question that I would ask is, how do we not just survive in the system? How do we create our own spaces? How do we do that? Of course we do, but I guess I would just go a little bit further with that.
Yeah, and first of all, I want to thank Southern Tier Prevention Services for inviting me and Tyree. Before I say this, hopefully I'll be invited again. I think I think it's important. Obviously, white supremacy culture, based upon my comments and sentiments before, plays a large part in this. But also, we got to be careful because on the other side of that is this white savior complex, right? And I think as we're having these conversations around ending the epidemic, we got to be careful of both the white supremacy culture of that shows up. And when I think of white supremacy culture, what I'm talking about is this idea of perfectionism, this idea of elitism, this idea of coming for a solution without really diagnosing the problem, right? That's white supremacy culture, right? So when I am speaking of the white savior complex, right, I am talking about this idea that we can do this for you. I know we're going to talk about allyship in a little bit. That's not how allyship works. Allyship works where the people that are most affected devise the plans. I am a part of many conversations around the country around ending the epidemic. Many times I am the only young Black queer person, specifically young Black gay man, who HIV is most affecting. And so I get in these conversations and they're like, oh, we have to do these focus groups, that we have to do these community assessments. We got to know what the community wants because we have to get the data. The data is going to inform our ending the epidemic plans. Girl, shut up. Shut up. Okay? That is not how this works. That's not how any of this works. Okay? What you need to understand is if we are not devising the plan, if we're not working through the plan will not work. It won't work. And so we have to be careful of not only white supremacy culture, but we also have to be careful of this white savior complex.
That was beautiful. And you will both be invited back time and time again. So if there's even any questions about that. If I have anything to say about that, because this is great. Okay, so just take a second to digest that because y'all just gave me some great magic right there. I love Black magic. Okay, so for my next question, see, it's so funny that I'm asking this question because I was recently speaking to someone who said that they went to the hospital with a Black woman and she received horrible treatment, just they said that they literally looked at, you know, white people being treated within the same emergency room setting as them, being treated with so much care, so much more just compassion, just so much more attentiveness, period. And I think about that, and I think about how, you know, we learned that, you know, Black women aren't always believed in medical settings, and there is a history of Black women, and not specifically Black women, you know, in those medical settings, but Black people being treated a little bit less than kind compared to their white counterparts. You know, some doctors are like, oh, Black people, you have Black skin, so your skin must be tougher, so therefore your nerve endings can take pain. And we've heard conspiracy theories like that. And so, which is why I wanted to address this. And I guess this question for you both, how does racism, is going to be a 1-2 part question. First part, how does racism within public health centers play into the HIV impact on communities of color?
Yeah, I want to take this moment to lift up some things that are really important, specifically language justice. Right, I live in Texas once again, where we are. I live in Houston, Texas, the most diverse city in America. I bet y'all didn't know that. But Houston, Texas is the
I
most
did not.
diverse city. Yeah, it's the
I thought
most
New York
diverse
City
city
was,
in
but
America. It is not. It's Houston. Houston is the most diverse city in America. And what we found out, so we did some work with End HIV Houston. It's a local coalition of multiple organizations that is ending the epidemic of HIV here locally in Houston. And they did um, a secret shopper project where we went to multiple agencies that work with persons living with HIV or persons impacted by HIV. And they scored them, kind of like the Better Business Bureau. But some of the findings that we found out, listen, we about to work down here. No,
yes.
no, but what we found out is that one of the things that is many times overlooked is this language justice. So there's people that cannot speak, there's people that cannot hear, and there's also people that speak a different language. They were treated in an incredibly worse way than even Black people or Latinx people in general, right? They were treated much worse than that. And I think it, I think, you know, when we think of racism, you know, obviously I always want to lift up, you know, the Black voices, but there are also Afro Latinx people and just Latinx people in general that we are completely missing that really, really need us, especially as it relates to our FQHCs and CBOs who are permitted to see these people and get rebates, amen, get rebates for seeing these people who are undocumented, right? Many times, even for me, there were years and years and years and years working in public health, making $32,000 a year on the front line. Amen. I was not able to afford insurance doing this work. And so FQHCs were the only spaces that I could go to get my health care, right? And so how did that show up for me if people who speak a different language or cannot speak are treated bad? If me as a gay man I'm reduced, okay, I have a fatter body. I have never been tested up until I got a new doctor for diabetes or high blood pressure. They they did all of
Mhm.
the regular stuff, but I was
Right.
reduced to my sex and or my sexuality. It was just
Right.
the HIV test. I'm a whole fat. I wear it well. I look good, but the point is, the point is, I am a fatter body. If you would have saw a Black male, you would have did a little bit more. But because I told you I sleep with men, it's just the HIV test. So I think it's a lot of intersecting issues when we talk about like the racism of public health. It's racism, it's sexism, it's transphobia, it is it is it's xenophobic, it's anti-immigrant, right? It's all of those intersections. And like I started this conversation with saying, if we cannot cure that, we will not end HIV. Period.
Very true.
So for me, I think that, just kind of piggybacking off of that comment, I did a talk a couple years ago with some residents here in the family medicine program about anal health and just anal health in general, because that is very much it's a newer field, right? For not just for people with HIV, but for anybody that has anal sex at all. And so in implementing that, integrating that into family medicine or just internal medicine practice, right? Doing an anal swab, knowing how to do an anal pap smear, knowing how to educate on anal health, right, is something that we don't get. And so I've got folks that come in with full-blown anal cancer, stuff that, from HPV. So, one of the things though, that it was very clear to me that they weren't interested in hearing what I had to say about it. And that when we talked about performing an anal swab, they were just like, and I remember I complained to the resident director because they were like, well, that's just another swab we have to do. And I was like, well, what? I'm sorry. But that's also part of, like, to hear that you were not given, just a regular old lab work that you deserve to have. Like, even with just regular labs, they can detect diabetes and high blood pressure, issues of high blood pressure within your lab work. But still, that is part of your patient. It's a part of the patient bill of rights ish, right? Like, you have the right to be tested for regular primary care issues, preventative care measures. So that's not good care. It's not good care to not know how to perform an anal swab or an anal pap smear, or how to educate folks on anal health, proper anal sex, how to douche, like how to make sure that you're using, what lube are you using? Like, how much are you using? Are you coming in with repeated fissures? Are you coming in with anal, because again, when people don't know how to do that correctly, I see anal abscesses that put them in the hospital, right? So those are things that, like, we see that there's gaps in care that happen because they're just too busy, or they just don't care. There's a stigma around anal health. There's a stigma around that it eventually affects our folks, our community, that needs to be addressed.
Thank you for speaking on that, speaking on that stigma around anal health, because that's something I have never even heard, really a physician specify like in that subject when it comes to the clients that we may have, we do have clients who engage in that. So thank you for definitely touching on that. And I want to segue into my next question, which I think both of you would have great tools for. I'm sure when we see different types of isms, people being treated wrongly, depending on whatever group of marginalized people they belong in, right? We see it and we want to do something, and we know that that's there. And so to take those steps in fixing it, my question for both of you is, for public health workers who see that and want to fix it, what do you do? How do we fix these things? If we could start from the inside with the public health workers, how do we fix these forms of prejudice that we see in the public health field?
So I'm going to start, since I'm constantly battling this right now. I think that in order for there to be definable changes, and I'm talking about organizations and healthcare centers, FQHCs, in order for us to for Black and Brown people to actually make changes that will directly impact Black and Brown queer folks, Black and Brown folks in a positive way, we have to be at a level within the organizations where we can make key decision changes. If we're not there at the executive level or the CEO level, that these changes are not disseminated down into the actual organization, things don't change. And just to talk about what was discussed earlier, everybody's trying to do a committee. Everybody's trying to do, a working group, or let's get together and make this, do these, let's examine it, like a house is on fire. Let's examine the house. Let's examine why it's on fire. Let's examine the reasons why, it all of a sudden caught fire so quickly, but nobody wants to put it out, right? Because where's the money in putting it out? So there's the thing I think that will change is if we are at these key decision-making positions, at least just to start the conversation.
I think that's great. I'm in love with you, Miss Miss Shani. Everything you're saying is just feeding my soul. Okay, it's so important to hear. I think that what I can add to that, if there's anything, is that healthcare should be a symbiotic relationship. Um, I am the expert in my life, and you are the expert at medicine. So when I come in, right? When I come in, when I have conversations with you, be clear that I know what I'm doing, right? I may not know the medical effects, right? I may not understand symptoms because that's what you're the expert at. I am the expert at my life. And it's really just easy if you create a relationship where I am not coming to you because you know everything about me, because you understand medicine.
Mhm.
If you let me know everything about me and you know everything about medicine, then we can have a really, really good relationship. Because the truth of the matter is, if I feel comfortable telling you what's going on with me, then you can, in your expertise in medicine, be a lot more capable of doing what needs to be done. I was having a conversation with my PCP recently because I had what I thought was an enlarged nipple. I had an enlarged nipple, and I was scared because although Black men, there's not a whole lot of breast cancer. I didn't know what it was. I went to a dermatologist. I went to a person that does like breast augmentation and all that kind of stuff, and nothing. It's just a large nipple. So I went to get a mammogram. I was serious. I needed to figure out what it was, and it ended up just being some probably sucked on it too hard. Who knows? But the point is, I needed to know what it was, and when I brought it to my doctor, you know, originally we have a good relationship, so she's not a bad doctor, but originally she laughed like, Ian, what's going on with you? Like, said, no, no, no. I'm clearly the expert in my body. I look at my body a lot more often than you look at my body. So
Mm.
I think it's really about having a symbiotic relationship. I also think it's important for us to, when we're thinking about advocacy, to create advocates in the doctor's room. And what that looks like is to be really clear. Even if you do not have insurance, and I'm in Texas, y'all know they didn't expand no Medicaid, and they trying to put more limits on us down here. But even still,
That's wrong.
you have choices. You have choices of your health care. And if this place is not working for you, the doctors work for you. The physicians work for you. The physician's assistants work for you. They get paid because you come in. And so you got to be able to, in your advocacy programs, in your frontline programs, in your HIV testing and counseling programs, you got to be telling people and reframing the conversation, because we, as as Black and brown people, we are not used to going to the doctor. So we go to the doctor to hear bad news. And so because of that, because the structure, white supremacy and patriarchy, because of the structure of hearing bad news means being reprimanded, we look at doctors as if they do something for us. They do. They do a lot. They have a lot of expertise, but they really work for you. And so if they
Mm.
don't work for you, then they don't work for you. Period.
Mm. I love the way
I love that. Yeah,
Yes, I've never heard it
love that.
worded like that before. Doctors work for the patients. I
Yeah.
love that.
So can I add to that? Because I think that's really
Absolutely,
important.
yes.
I think so I became a PA because of my experiences in healthcare. I have a chronic pain condition that was ignored by my doctor because I had no insurance,
Mm.
right? And so, that's how I became what I am today. And the thing is too, is like, it is our job, especially as Black and brown providers, to help our patients navigate a system that is designed not to work on their behalf. And it's kind of like a decoder, right? Like if you're looking at like if you're looking at a magnifying glass and it will all of a sudden tell you what's wrong. If I have a patient that tells me, for instance, you're enlarged nipple, the mammogram, like the ultrasound, the lab work that you received hopefully was what you should have gotten, right? That's appropriate care. But
Mhm.
I think though that it's like The other part of that is, you know, if you have knee pain and you're seeing me for knee pain, and I'm like, okay, well, here's what you like. This is honestly what happens. You come in to see me for knee pain. I'm like, okay, here's what you say. Here's how you say it. Here's what you say to here's who you bring with you. Here's the
Mhm.
question that you ask. Here's in order to receive appropriate care, because that's what this system is designed to. You have to make sure that the system is designed to work for you. Those are the providers that people should be looking for. How do you work within it? How are they working for you within a system that does not work for you? How does it like, and that is like that type of mindset in medicine is what saves people's lives. Black people and brown people are dying from lack of experience, lack of care. That's happening now. So when I talk to folks, like for instance, you know, we had I work in urgent care now at a federally qualified health center, and you know, folks come in, bread and butter is STI testing. So we do, you know, two 18-year-old girls came in, and like, you know, this place is the what that I work is some issues. Some of these folks have issues with, you know, their how they speak about things, and so we've had to really work with that. But the one 18-year-old, it was two sisters. One came in, and they came in to get STI testing, and one of them was like, "Well, my sister's here. She just started having sex, and this is her first time getting tested, and she's really nervous." And so I was like, "Thank you for coming in today. Here's what you can expect from this visit. You know, how can I answer any questions you have? You know, do you like, do you know about condom use? You know, are you on birth control? Do you have a doctor? Do you have a GYN that you see? Do you have like da 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 da? You know, what is it about? What are you most nervous about going forward? You know, do you feel safe within your current relationship? You know, what does safety look like to you? So those types of questions leave people feeling empowered and thinking about, I want them thinking about what they should be doing after their visit with me in order to live the best life they can. Condom or not, condom or not. Because again, you're right. I can't control what y'all do outside of my office, but I can hopefully empower you in order to live the best life that you want to live.
Perfect. I love that. I love that answer. Um, I want to take the last 5 minutes that we have to talk about what a very important, question that I have for both of you. As Ian touched on it earlier, I want to talk about allyship and take the last 5 minutes to kind of unpack that. I guess unpack that word. I think that is very impactful for our community and can really help save a lot of folks. So, for both of you, in your own words, what does true allyship look like? What does that truly, like a true ally? I know we've all heard the word woke and unwoke, but like, what does a true ally for LGBTQ plus individuals and Black people, brown people, what does that look like to both of you?
You know, I'll start with this because this is a really important concept for me. I got to sit back and fix my swim trunks because y'all only see the top. It's Zoom. Um, so, um, allyship looks like sacrifice. Allyship is sacrifice. It's sacrifice. I remember before I had learned the language of allyship and accomplices and all those activist words that we now use, I was a, in a conversation with a wonderful woman that lives in NYC, and she is white. And we had a very transparent conversation around how she perceived me originally because I do have a deeper voice. I am a bigger body. I'm stocky. And I also, y'all can't see this, but I have a lot of tattoos, right? I wear my pants below my waist when I'm not at work, amen. And I'm very urban, okay? I'm very urban. And so she was honest about how she perceived me, and I was honest about how I perceived her. And they were both clear generalizations. The only difference was her generalization could have killed me or got me in serious trouble. And my generalization was just that, a stereotype, right? And what we begin to talk about is in our conversation that true allyship is not only acknowledging your privilege, right, in that scenario, but it's leveraging that, right? Allyship is the sacrifice of leveraging privilege. But this is what's important to me when I think about allies, because I think Black, Brown, men, women, and people in the non-binary often think that it only comes from Caucasian people or white people. We think of allyship as what white people need to do for Black people. And that is untrue. Because I would argue, unless we have a Black or brown trans woman listening on the line, that many of us have intersections of privilege. Intersections of privilege from education to presentation, to who we love or how we love, to where we live, to what we drive, where we work. We have an intersection of privilege. And anytime you have an intersection of privilege, you have an opportunity for allyship. It's an opportunity to sacrifice, to leverage that privilege to benefit the most marginalized. So I want us to, if there's anything that I could give the community of public health practitioners and or the community of advocates or just community, is that whatever your intersection of privilege is, you owe it to the movement to sacrifice and leverage your privilege.
Thank you. Thank you, Ian. Thank you so much for that. Shani, how about you?
So I'm not going to add much to that. Only thing I'll say is that, for me, allyship is more than discomfort. It is sacrifice. And that's all I'm going to say.
Perfect. Well, thank you both. I want to say a big thank you to both Ian and Shani for joining us today. This has been such an amazing, powerful, super fun talk. Thank you all for attending. This has been great for all of you. And I hope that we all get the privilege to do this again together in the future. So thank you both. Shani, hope you're doing good in Rochester. Ian, enjoy Texas. I think it's good down there. And I hope you all have the best rest of your day and have a good weekend, everybody. Stay safe.
Have a great day.
You too.